Good to go? All right, sounds good. Good to see a full house except for the front row. We have a couple of brave souls way off to the side. All right, as Lou said, we're going to talk a little bit about ventilator synchrony and things related to ventilator synchrony. We're going to talk about recognizing a role for volume-targeted ventilation in many critically ill patients. Recognize that ventilator waveform patterns of asynchrony may provide really useful information about the patient and the ventilator, and identify ventilator overdrive as means to manage many types of asynchrony. You all are very aware of the concept of compliance. So when choosing a mode between volume cycle versus pressure cycle, it may not make a whole lot of difference in that the two are intrinsically related, volume and pressure, as defined by a patient's compliance. So for any given volume, you will end up with a set pressure depending on that person's compliance. Unfortunately, compliance may change for a patient. It's not a static condition, and it may change over a period of minutes to hours to days, depending on the patient. Changes in fluid status, changes in inflammation, and changes in body position may change compliance, and therefore change one of these parameters based upon if the other is set constant. And in particular, if you're using pressure modes and compliance changes, you can expect that tidal volume to change. If you're in a volume mode and compliance changes, you can expect the pressure to deliver that breath is going to change. We know in ARDS, tidal volume is very, very important, managing tidal volume. This was a study published almost 18 years ago now, looking at 861 patients with ARDS, and patients were randomized to 6 cc's per kilogram of ideal body weight versus 12 cc's per kilogram of ideal body weight. And we found that there was an absolute mortality reduction of 9% when patients received the 6 cc's per kilogram of ideal body weight. So again, tidal volume is very important to our patients, certainly with ARDS. When we talk about pressures, though, what pressures are we really going to talk about? Well, we know about peak pressures and we know about plateau pressures, and sort of by definition, we know that a plateau pressure is defined as the pressure to inflate the lungs in the absence of flow. So you deliver the breath, stop flow, and then measure the pressure. And that's really the pressure that's important to the lungs when it comes to lung injury. The peak pressure, the three components of peak pressure being PEEP, plateau, and then pressure to overcome resistance to flow, is also dependent upon this pressure of resistance. And again, that's a pressure that's entirely related to flow through the breathing system from ventilator to bronchial tubes, and doesn't get transmitted into the alveoli, and so therefore is less important to the patient, or in fact not important at all to the patient. Really, it's the plateau pressure or pressure of elastance that's most important when we talk about lung stretch or lung injury. So again, tidal volume and pressure are related. There are some people that think that perhaps maybe it doesn't matter what the tidal volume is as long as the pressures are low enough. And this was a study that looked at, again, patients with ARDS, and they divided patients up according to their plateau pressure. And even with plateau pressures that were really quite modest in the 20 range, actually 12 to 20 range, they still benefited from low tidal volume ventilation compared to the 12 cc's per kilogram tidal volume. So again, no matter what the plateau pressures are, using 6 cc's per kilogram is safer, better for our patients than using 12 cc's per kilogram. So who cares about ARDS? The vast majority of our patients that we take care of in the ICU don't have ARDS. So why are we talking so much about ARDS? And this study looked at 10 different studies of patients without ARDS that in fact had healthy lungs going into their critical illness. The majority of these patients being sepsis with normal lungs. And when they pooled the results of all these studies, found that patients that were ventilated with 6 cc's per kilogram compared to 12 cc's per kilogram did much better, were less likely to develop ARDS than those that were ventilated with larger tidal volumes, and a mortality benefit as well. Again, so not just ARDS, really many patients in the intensive care unit are going to benefit from ventilation with low tidal volumes. So, again, what we know, lower tidal volumes cause less lung stretch. They're going to cause less lung inflammation and subsequently less lung injury in patients, particularly those with shock, those with sepsis, post-operative patients, also another important subgroup of patients with a marked mortality benefit when we use low tidal volume ventilation. So a question that needs to be asked is, well, is 6 cc's per kilogram of ideal body weight the best tidal volume? Don't know. It's certainly better than 12. We know that. Is 5 cc's better than 6? Don't know yet. Is 7 cc's better than 6? It sure is easier to give 7 cc's than 6 cc's, but we don't know. What we do know is 6 cc's per kilogram is the one that's been shown to improve mortality. Until we have more information, I think that's what we need to be targeting. There are some people that say, in fact, even in the recent surviving sepsis guidelines, that maybe 6 to 8 cc's per kilogram of ideal body weight's okay as long as the plateau pressures are low. And again, I refer back to this graph that we showed earlier. Even with low plateau pressures, 6 cc's per kilogram is associated with improved mortality. So again, I think that's our target until we have more information. And I think if volume is important, then volume control controls volume. Talk a little bit more about that. So let's look at this patient here. This patient has ARDS. We're going to start up with mechanical ventilation. Just have you take a look at that tracing there for a minute and see what you think about that tracing, and think about how you're going to set this patient up, assuming that that we know a little bit more information. This person is about 5'2". So what we're going to do, let's start off with tidal volume, okay? And I think we've already defined that should be 6 cc's per kilogram. For those that don't know how to calculate ideal body weight based upon height, there's a formula there, and it'll be in the notes that Lou is sharing with you as well. But height is the best predictor of ideal body weight than actual weight. Setting PEEP is probably beyond what we're going to talk about in this talk. Respiratory rate's an important issue, and that I find that perhaps we have opportunities for improvement in setting our initial respiratory rate. When we look at the ARDSNet protocol that defines 6 cc's per kilogram as the optimum volume, the average respiratory rate was 29 in those patients, 29 plus or minus 7. So again, if you have an ARDS patient, you're ventilating with 6 cc's per kilogram, I'd set that respiratory rate at I hate odd numbers, but 28 or 30, not 24, not 20, not 16 normal, but really a pretty high respiratory rate for starters, and then go from there. FiO2, obviously we're going to start at 100%. I'm not sure why it shows 30 here. And inspiratory flow, or inspiratory time. This is another point of discussion and that we're going to talk a lot about over the next 45 minutes. And I strongly recommend starting flow at about 60 liters per minute. And we'll go a little bit more as to why that is. And certainly I know that there will be some people that disagree with that number, and I'll try and explain why I think that's important. All right, let's again look back at this waveform. What do we see? Does this waveform look like we have a optimized waveform set up for this patient? See peak pressure is about 30, plateau pressure is about 17. I see a nice shark fin shaped to the pressure curve. A little bit of an inspiratory pause set in for measuring that plateau pressure. So my thoughts are that that waveform looks pretty optimized. So we'll start off with what sort of looks normal. Excuse me. Let's look at this patient, all right? Just showing part of the screen now. Is this person passive or active? Thoughts for a minute there. Some of you may recognize this really isn't quite a shark fin shape to it. I'll show you a little bit more of the screen, and we might get a little bit more evidence that this person might be active. We don't see any pink bars. For those of you that are familiar with servo ventilators, we don't see any pink bars saying this is a patient-initiated breath, so we might be led to think this person is passive. But we see some things going on here that really suggest that there's patient effort going on despite the lack of the pink bars. Also notice that shape, that is not a shark fin shape, and we'll go back and talk about that as the talk goes on. Again, evidence of respiratory effort there in the expiratory phase. Also recognize that in the pressure waveform, you can see a little dip here at the end of inspiration, and that really corresponds to some extent to this change in flow too. Mood lighting. Again, evidence of patient effort that is subtle, but definitely there. Another patient. Is this person passive or active? If you're not sure, I'll give you a little bit more of the screen. Okay, so we know this person's active. Right, now we see those pink bars there that says this is a patient-initiated breath. But even if we look at these initial breaths that I was showing you up front, that pressure waveform really doesn't have that shark fin shape that I described earlier on in the talk. And that might be a clue that this person might actually be putting some respiratory effort into the equation. What's the flow for this patient? My screen's low enough I can't see what it is. But even just from from the doorway, we know that flow is on this screen up to 100, and it's about half of that. So flow set at about 50 for this patient. And again, we see this person with an active waveform and an abnormal pressure curve. And again, compare this pressure curve to the normal pressure curve, just for comparison, recognizing that this is abnormal, and the reason it's abnormal is probably because of patient effort. And we'll talk more about that. As we said, flow in that patient is set about 50. You can check it directly by looking at it, but again, you can also notice from the doorway that the flow is really about half of that screen of 100, and so you know flow is relatively low. Again, looking at that normal waveform. So let's talk, again, what this talk is about synchrony, or really the absence of synchrony, asynchrony. Merriam-Webster dictionary defines it as the absence or lack of concurrence in time. When we're talking about ventilator asynchrony, we're talking about a mismatch between what the patient wants and what you're delivering with the ventilator. We do know that asynchrony in many cases will increase the work of breathing for the patient. We'll talk about 3 different types of asynchrony. We'll talk about trigger asynchrony, we'll talk about flow asynchrony, and we'll talk about cycle asynchrony. Before we talk more about asynchrony, let's talk about work of breathing, or excessive work of breathing. We know that excessive work of breathing results in discomfort. We also know that excessive work of breathing will increase someone's lactic acidosis. The diaphragm will get fatigued, create lactic acid, which, by the way, then increases one's respiratory drive to clear that lactic acidosis, which then increases work of breathing, which then increases lactic acidosis. So work of breathing is bad in many ways. Increased work of breathing does increase blood flow to the diaphragm, and in conditions where blood flow may be limited, that's taking blood flow away from somewhere else. So that may have systemic effects as well. We know that excessive work of breathing actually can lead to diaphragm dysfunction. And finally, excessive work of breathing can cause injurious inflation to the lungs. Again, we'll build upon that point too. Excuse me. This is a study done a few years ago now, actually just published this year, that really looked at diaphragm dysfunction in patients critically ill on the ventilator. And they're actually able to measure both the electrical activity of the diaphragm as well as diaphragm thickness using ultrasound. And what they found is some patients, the diaphragm thickness and diaphragm electrical activity increased, and some of the patients that activity and thickness actually decreased. What they found was that patients in whom the diaphragm did not change had the best outcomes. Patients whose diaphragms got smaller and had less electrical activity did poorly, but also interesting, patients whose diaphragms got thicker and increased electrical activity also did worse compared to those that didn't change. Again, increased worker breathing associated with increased diaphragm thickness and increased diaphragm electrical activity, so increased worker breathing.